TriNetX platform that you can use without downloading data. We picked a different article this time for walking through a published article using TriNetX that we will replicate the outcomes of as a demonstration of how do you set up the analysis in TriNetX to balance two cohorts and compare outcomes on them. So by the end of the session, you should be able to describe the capabilities of the built-in tools within TriNetX for running statistical analyses, and at least begin to use TriNetX for outcomes research. So before I jump into slides and the demo, does anyone have questions from last week? All right, hearing none, I'll proceed, but as before, feel free to holler as we go. I can't on my single screen here see anybody raising hands or putting things in the chat, so just holler. I will say that last night my wife called and said, hey, her mom is going into the emergency room. She re-dislocated a hip after having a hip replacement earlier in the year. And so after they popped it back in, the usual great care at the VCU emergency department with the emergency medicine team, orthopedics team, et cetera, they kept her for observation, and I was hanging out with my mother-in-law, and she was asking me what I've been doing lately at MCV, and I said, well, this clinical data research platform, blah, blah, blah. And she's like, oh, what kinds of questions can you answer with that? And I said, well, we could actually see how frequently it happens that someone with a hip replacement has a hip dislocation. And she was like, no, you can't do that. So again, you know how much time you have in the ED waiting for the next thing to happen sometimes. So we're just waiting for her to finish that recovery from the relocation of the hip. So I ran a quick query for her and a quick single cohort outcome. It's kind of just a real quick and dirty thing to demonstrate to her, of the 21,000 people who are 80 years or older who had a hip replacement, the risk of having a hip dislocation within 1 year is 1.4%. If you have one, the average number you'll have within 1 year is 2, which is where she's at. And so I showed her this is where you are, mother-in-law. You are in the 20-some% of people who, after having a hip replacement, have had 2 hip dislocations in 1 year. And she loved it. She just thought, well, this is great. Can you not just use this for research? Can you use this for this kind of thing where you're talking to patients about risk of outcomes and whatnot? And so it was a good conversation, and just a quick demonstration for us as well of once you're familiar with TriNetX, how quickly you can run a query and how quickly you can run an analytic. So this is literally within like 10 or 15 minutes in the ED on my laptop, was able to do that with her. And she asked great questions like, well, how reliable are the data and things like that. So it was great. So just a quick review of the analytics that are available within the platform. That was an analyzed outcomes that we just looked at for a single cohort. And this is also what was done in the article that I showed last week by Benjamin Van Tassel and colleagues from cardiology and pharmacy here at VCU, looking at the incidence of heart failure after an anterior wall STEMI. So single cohort outcomes are certainly publishable. What we're going to spend more time on today is a demonstration of comparing 2 outcomes, because that entails also balancing cohorts. And that's just a useful thing to review the logic of in observational research and the rationale for balancing, as well as the steps that TriNetX walks you through. It's a series of steps that are not, each one of them is not complex, but until you see the whole set of them run one after another, it may be difficult to try to do a compared to outcomes analysis in TriNetX yourself without having seen one. And we're not going to look at these additional analytics today. Here's that Van Tassel paper. Again, I just wanted to highlight something different than what we had looked at last week. We were focusing on the 1 minus Kaplan-Meier cumulative incidence of heart failure over 1 year. But of course, table 1 in any article is going to be the description of the population or the sample. And you can get all of these data points for such a table, not from the analytics per se, but from an option before you go over into analytics of Explore Cohort. And I'll quickly show what that looks like as well for one of the cohorts we'll do from the Abramhoff study. So these are the 5 articles that we glanced at before. Last time we walked through the queries that went into the Buckley paper. So replicating the inclusion and exclusion criteria for that study with cardiac rehab. And today we're going to do something similar, not with the query building, but with the analytic side of the Abramhoff paper. So this is what that looks like. And again, the first step when I go through these published articles to see, well, how would I do that? What would it look like if I tried to write such queries and do such analytics, is to pull out their research question and either their PICO or their PO, or here their PIOT for their study. In their introduction, they phrased the research question in 4 different ways in different sections, all of them essentially the same thing about longer term continuation of symptoms and other outcomes after COVID diagnosis, comparing a cohort of patients who had multiple sclerosis, traumatic brain injury, or spinal cord injury compared to patients with COVID who did not have those pre-existing disabling conditions. So the population is patients with COVID. One cohort is exposed, in a sense, to having those pre-existing conditions, and the other is not. And the outcomes that they looked at, we're not going to do all of these. We're going to do a couple of these, so you get a sense of how you'd set up an outcome for hospitalization versus death versus a symptom. But I'm not going to do all the 6 or 7 symptoms. And the time frame for the outcomes was 6 months after COVID. Drilling down a little bit, I always do this step as well. So just making sure that I have all the details, either that I'm proposing in my inclusion exclusion criteria and kind of the timeline for when events happen, the clinical phenomena for the cohorts. Or if I'm replicating someone else's study, it helps just to pull out the codes as well. So their population or their cohorts are patients who were 18 years or older at the time of a COVID diagnosis between March and December of 2020. TriNetX has a couple of pages in its help area, help center, that take you to guidance for lassoing COVID patients and what kinds of search terms to use. And from that, here's what terms to use, including an RNA lab and another lab that specifically for COVID, codes for multiple sclerosis, TBI, or SCI. And that was at least 6 months prior to COVID for the cohort that had those things. And the way I operationally defined what the time frame is for people who didn't have it was that they didn't ever have TBI, MS, or SCI before COVID or in the 6-month outcome window. The outcomes are shown here with the codes, and that's within 6 months after COVID. And then also looking to see what kinds of variables they included in the propensity score matching process. So generally, these are covariates that may affect the outcome that you're looking for, that you're using to make sure that you're comparing apples to apples, in the sense of you want the 2 cohorts to look as similarly as possible, except for the variable that you're differentiating them on. So you want them to be differentiated on the presence of these premorbid disabling conditions, but you want them to be equal in things like age and race and sex, but also things like comorbidities. They had used the Elixhauser. They actually downloaded the data for their paper, which we're not going to do. And they had computed the Elixhauser comorbidity index, but we could pick a couple of the kinds of comorbidities that are in the Elixhauser and do that ourselves in the propensity score matching without using the whole scale. So each cohort has the same criteria, and I set these up yesterday. So both cohorts have the same criteria in terms of COVID. So in the query builder, 18 plus at the time of having any one of these indicators of having COVID, and this whole group of terms, this group of criteria occurred in that March to December 2020 timeframe. For the cohort that had a TBI, SCI, or multiple sclerosis 6 months or more before the COVID diagnosis, I repeated having those COVID things in another group of criteria and then did a related group. This should sound familiar to those who were with us last week. Specified a related group that is chronologically related, and that's where I have my intracranial injury, MS, etc., that occurred at least 6 months before any instance of COVID. So that's using that related group function in the query builder to set up a temporal relationship between two inclusion criteria. And for the other cohort, it's essentially an exclusion criterion. So I moved my intracranial injury, SCI, and MS criteria over to the must not have side. And my temporal relationship here is just a little bit different. Any instance of not having those things occurred before up to 6 months after COVID. Again, repeating the COVID conditions and setting up a related group 2A and 2B to do that. So as I switch over here, any questions about this setup? All right. So this is what those two queries look like in TriNetX. When I count patients, it saves my queries over here on the right-hand side, and this is a history of the queries that I'm running within my replicating Abramov study. So a study or a project can hold lots of different queries and analytics in it. And as I said, I have, if I expand group 1, here you can see the COVID criteria. And in group 2, that's the temporal relationship between COVID and either having or not having those pre-existing conditions. And I have about 5 million people who had COVID without those, and I have about 120,000 people who had COVID with those. So just in terms of the N, hugely imbalanced at this point. Before I go over to popping them into an analytic to compare, I do want to show you a couple of things. So remember, there's the design assistance button here. If you want to reach out to the tech staff at TriNetX and say, is this still the way that you would set up a COVID cohort? Or I want to make sure that I'm getting that logic correct for not having traumatic brain injury, et cetera, in relation to COVID. Did I set that up right? And under study management, you can also share your study. So again, one of the great things about TriNetX is that you can, so I can search for Dr. Karmarkar. There he is. And I can save my team. And now he has access to the queries, the analytics that are in here, everything that's in my replicating Abramov project or study, he has access to. And if we wanted to upload documents related to our research protocol, properties, change the properties of the study description, we can do that here. The other thing I wanted to show you that we didn't really go into much last week is this Explore cohort. So these are the 120,000 or so people with traumatic brain injury, MS, or spinal cord injury before they had COVID. And here you can see their demographics. And here you can go down to diagnoses if you want to explore those. And you can see what they have. Lots of comorbidities in these groups. But you can see other things, their procedures, their medications, etc. So this is where you would build up information for table 1, for example. We're going to go down to analytics. So if I was only interested in looking at the analytics for the COVID with pre-morbid conditions cohort, I could do that and look at the outcomes here. And I did, in fact, set some of those up last night so I could look at things like hospital admission and death and dyspnea, and then look at the descriptive results just for that one cohort to see what their risk of, so the first thing was hospitalization, 1 month to, I think I did 1 month to 1 year after the index event here. So 11% hospitalized. You can look at multiple hospitalizations and the time to event. 3% die. You can look at time to event for that. And 14% have dyspnea. And you can look at the time that I find this to be pretty useful before I go into comparing to cohorts on outcomes and doing the matching. Because when I do the matching, it's going to reduce my sample to the matched people. So we're just going to do this live, where I compare in cohort 1 people with COVID and the premorbid conditions, and in cohort 2 the 5 million people without them. And then these are the steps that TriNetX wants me to do to balance the cohorts. And before we go into that, just a quick reminder from your research courses in the past that when you're doing an RCT, randomization takes care of the bulk of making sure that your cohorts, treatment A and treatment B, or cohort 1 and cohort 2, are through randomization more or less equal in terms of their pre-existing conditions at the time of randomization. In observational data, we don't have randomization, but we still have that problem of, if we're not randomizing, we have a lot of potential selection bias. So we want to make sure that we have enough balancing of the two cohorts to ensure that we are saying all of the things as equal as we can make them, at least on the observed characteristics that we can match them on, and what is the power of the differentiating characteristic in looking at risk of an outcome. So these are the steps that you need to go through for doing this. The first one is to set a time window for what is that baseline time period. It's not well labeled here, but they're looking for the baseline time period. In the article, they actually said for some of the symptoms that they're looking at for outcomes, they also balanced on those as pre-existing symptoms, and they did that for 6 months prior to the index event. The index event for both cohorts is the COVID diagnosis, right? So again, if we're doing an RCT, we'd be randomizing at that point. In an epidemiological study like this with observational data, we can't do that, but we can say, when we look to create as much balance as we can between the two groups, it's as if the index event is a very important line that we're drawing. And we have our baseline time period beforehand, which is where we're going to look at characteristics on which the two cohorts need to be balanced. And then we have the outcome window after that index event. So that's essentially all we're doing here in this first step. And I have not run this before, and I don't know how long it's going to take to begin to pull the data together to do the balancing, given that one of the cohorts is so large. While that's running, anybody have any questions they want to holler out? Anybody have any questions about my mother-in-law?
I have a question about the platform. This is John
Yes.
Hermanson, one of the VA docs. And I apologize, I missed the first couple of minutes of the lecture, but how do you have what enables access to this platform? Is this through VCU, through VA, or both?
Through VCU.
Okay.
So in the slides for the session last week, it has the steps to get access from folks at the Right Center.
Okay.
So if you have a VCU appointment, you just use your EID essentially to get that, and VCU Health staff and faculty can get that as well. So it's pretty straightforward to get that.
Awesome, thank you. I do have that. I'll reach out to the chiefs to get a copy of the slides.
Sure. And then it's always the dual authentication. So I have to do that. It's the data are essentially kind of housed on the VCU health system side. So I have to do the dual authentication on the health system side, not the VCU side. So the next step it started to prepare the data for my balancing. And now I need to tell it which characteristics in that time window of a baseline am I going to look at to balance the cohorts. And demographics are easy. I could do current age or age at index or both. I'm going to do age at index. So the way to tell TriNetX which characteristics I want it to use is to click the star. Can do sex or gender. And just because I don't click unknown sex here doesn't mean those people will be excluded. What this is doing is it's going to, by clicking here, it's going to match females to females and males to males. It won't necessarily match unknown sex to unknown sex unless I click that. But it's not throwing those people out of the study. It's just whether the variable is used as the basis for the one-to-one matching, if that makes sense. So we can do ethnicity, can do race, can do a whole bunch of these. It will run into resource issues at some point. So I'm actually going to pick not all of them in demographics so that I hopefully have enough computational space for a couple of the other things. So they did the Elixhauser Comorbidity Index. Remember that the outcomes that they're interested in include things like death, hospitalization, and symptoms such as mobility issues and dyspnea, weakness and fatigue, those kind of long COVID symptoms. Of course, there's a lot of other conditions that would lead to those and that we want to balance the cohorts on so that we can see whether having TBI or SCI or MS has a significant impact on the experience of those long COVID or poor outcome conditions. So in addition to the demographics, I could go into diagnoses here and I can search for specifying, well, if this is the easiest way to do this. So I can ask it to look, for example, for Alzheimer's. and it's showing me that there's not a particularly good signal for that. So you have the signal thing here, but there is a strong signal for the broader category of other degenerative diseases of the nervous system. So I'm going to save that broader category. Um, and other diseases of the musculoskeletal system and respiratory system, right? Because I have things like dyspnea and muscle weakness and fatigue. So also including some of these here will help me to balance my um, two cohorts so that I'm able to detect specifically the signal, the power of the premorbid conditions of interest. So now I'm asking it to take those 10 characteristics. I don't know if you can still see down here, saved characteristics. There was 10 things that we starred, mostly demographics, but also a few conditions that are potentially related to my outcome on which I want to make sure the cohorts are balanced. Any questions? A little bit slower than we'd like for a live demo, but considering it's chomping through 5 million patients worth of data, it's pretty darn fast. Okay. Now, underneath of these, it has not fully incorporated the information from these baseline characteristics. So I'm going to click run again. Well, I'm going to see, maybe I can skip to balance cohorts. You can make some modifications here on this screen. Now I'll click run. And so now it's actually going to take the information on those 10 characteristics for my two cohorts, 5 million people here, a few 100,000 people there, and perform the one-to-one matching. So essentially it's taking the smaller cohort and it's saying, okay, given the characteristics that you told me are important, if I have these 100,000 or 200,000 patients with TBI, et cetera, what are my one-to-one best matches among those 5 million people to do my outcome analysis on? So that's how it, in terms of the logic of this, is setting it up. It's not going to throw out too many people of the smaller cohort since it has so many people within the other cohort to choose from. There's certainly other ways to balance cohorts outside of TriNetX. So in observational research that I do in palliative care, we usually do propensity weighting instead of propensity matching. In some older studies I did, my statistician did a 3-to-1 matching and not a 1-to-1. So there's different ways that you can approach this. In one study I did, we did a combination of exact matching and propensity score matching. So first we stratified by disease type for people receiving or not receiving palliative care. Then within each disease type, we did the propensity score matching. The propensity score is from a logistic regression, looking at the impact of those 10 characteristics on predicting whether people had or did not have your differentiating characteristic, which here is the exposure to prior MS, TBI, or SCI. Okay, so the output you get, here's where we're at now on our menu of steps. So we told it the inputs we wanted to use, and now it's showing me and you the results of the matching. We haven't told it what outcomes to look for yet. So it took these 121,472 patients with the premorbid conditions and didn't throw any of them out. Among the 5 million patients without those, it found good enough matches for every single one of those. The propensity density function thing we're going to skip, but looking at the standardized differences between the two cohorts based on these 10 characteristics, the cutoff that people usually use is 0.1. So you can see that there is a great deal of imbalance in not being Hispanic or Latino, with a standardized difference of 0.33 before matching, and now it's much less than 0.1, 0.0009. So you can see 80% versus 66% before, and now it's 80.4% and 80.5% after matching. So you can go through each of these and just double check that your standardized differences are now less than 0.1, just to show that you've done this correctly, and that's also something usually reported in an article. I know what outcomes I'm interested in, so I'm going to skip exploring the outcomes, and I'm going to tell it what outcomes I'm interested in. My first step here is to select either before or matching, and a lot of people will do both sequentially. First, they'll do comparing before, and then they'll do after. I've already looked at some of the results just for the TBI, SCI, MS group, so I'm not going to do that. I'm going to just compare after matching. The second step is to set the time window for the outcomes. So the time window we did before was setting the the time window for the baseline characteristics. I don't know if they had a cutoff for after diagnosis, but let's say that it's 1 year, 1 month to 6 months for dyspnea, hospitalization, and death, and things like that. We've already set the index event, so we don't need to do that. And I can hide or minimize that whole step. I'm not going to look at follow-up time right now, but that is something they recently added. I do want to show you how to put in the outcomes. So you could do multiple outcomes. You specify them in time, and a given outcome can have multiple indicators of it. So if there was multiple ICD-10 codes for dyspnea, I could put those in here. One of their outcomes was death. So I can select that as one outcome and add that to the query. And I can do a measure of association for that, for the risk or odds ratios. And I can do a Kaplan-Meier. And I can give this a name. So when I look at my output, it's a little bit easier to follow. I go down below that and I specify a second outcome. And this can be initial hospital care. And I use the CPT code for that. This is the family of CPT codes that's related to initial hospitalization care. You can do more specific ones if you want. And they looked at a couple of things. They looked at both any hospitalization to do a measure of association for that. I don't want to exclude patients with the outcome prior to the outcome window. Don't necessarily need to do a Kaplan-Meier for that, but they also looked at number of instances, how many hospitalizations. And again, I don't need to exclude them, and I can tell a couple of other different ways that I want to control how it's operationally defining that outcome. And I'll give that a name. And then the third kind of outcome that they did was symptoms. So one of those was dyspnea. So I can do that. And here I'm just going to do a measure of association. I'm not going to do number of instances or whatnot, but I'm going to give that a name. So it's the same kind of interface, right? You're using that same kind of searching interface that they had in the query builder. If I start typing in letters of a phenomenon, it'll start to give me hits, and then I can use the term hierarchy to make sure I'm getting the right codes in there. So that should all seem similar. So now I have 3 different kinds of outcomes that I'm looking at for my balanced matched cohorts. Any questions about the inputs? One of the questions students sometimes ask me about propensity score matching is, how do I know what kinds of variables to include? And in part, that's a statistical question, but also it's a subject matter question. So if you know the kinds of um, predictors or phenomena that are going to be related to your outcome, those are the kinds of things that you'd want to include. For example, we're saying that since things like fatigue and muscle weakness are, or for dyspnea, we'd want to make sure that we included things like heart failure or other cardiopulmonary COPD, and things like that that may be also causes of heart failure. And we don't want to eliminate people who had those conditions from the analysis. We just want to make sure that our 2 cohorts when it, are balanced on those things. So a combination of subject matter expertise and um, a little bit of statistical acumen for knowing what to include in those. Again, pretty amazing how quickly it works. So it's repeating up here some of the information that we already knew. It's already giving me the option to export my results either to a combination of CSV files and pictures or to a Word document. The Word document is nice because it includes what TriNetX is, all of my criteria that were into the queries, and how I set up the analytic and what the results were. So you don't have to do screenshots. You can use either of those export functions to pull things into your papers and posters and whatnot. It's going to repeat some information here about the propensity score stuff. I'm going to minimize that so we can look at the actual outcomes. And the first one was death. So our 2 cohorts with MSTBI and SCI are the purple, and that's going to be on the top. So that's cohort 1. So 1.6% risk versus 1.2% risk of having death with between 1 and 6 months after COVID for the 2 groups. The risk difference is 0.44%. The z-score is high for that risk difference, and the p-value is very small. Sorry if these are small and hard to see on your various screens. And my risk ratio is 1.4, and the confidence interval around that does not cross 1.0. That also indicates that this is a significant thing that I shouldn't chalk up to chance or uncertainty. So patients with MSTBI or SCI have 1.4 odds of death compared to patients without those after COVID. Kaplan-Meier is not shown to me much on the curve, but here's the log rank test that's statistically significant. The hazard ratio for that. My next outcome was hospitalizations and having 1 or more, and then also the number of them. So same kind of output first on the measure of association, that my cohort of interest with multiple sclerosis, traumatic brain injury, or spinal cord injury has a 6.9% risk of hospitalization 1 to 6 months after COVID, compared to 3.5%. Huge Z-score, small p-value on the risk difference, almost a 2 risk ratio of 2. And again, my confidence interval is not crossing 1.0. So I know that that is a robust finding. So my odds of being hospitalized, if I have these pre-existing conditions, odds of being hospitalized after COVID are almost double for that group compared to not having those conditions. The other thing I did for this particular outcome was number of instances, again, following the what they had done in the published article. So now it's saying, okay, of the patients with the outcome, does the number of instances differ between the two groups? I have a huge sample size here. So even though my difference is pretty small, 2.0 versus 2.2, it's statistically significant. The number of hospitalizations is higher, 2.12 versus 2.03, higher in the TBMS SCI group. And our third kind of outcome that we're looking at is the incidence of dyspnea. This could have been pre-existing. It may not be COVID-specific dyspnea, but the having at least one visit with a dyspnea ICD-10 code on it between 1 and 6 months after COVID is more likely in the MSTBI SCI cohort than it is in the other cohort. 8.4% versus 5.7%. Big Z-score, small p-value on the risk difference. Risk ratio 1.5, 95% confidence interval doesn't cross 1.0. This is what I do out loud for my medical students. Sorry if it's sounds like I'm telling you things you can see for yourself, but just like to interpret some of these things out loud for folks who don't look at odds and risk ratios every day. So your odds of having dyspnea 1 to 6 months after COVID are 1.5 times greater with those pre-existing conditions. Again, if I clicked export all, that would happen within 10 or 15 seconds. All that output would be put into a Word document for me. If I go back to my analyses, I can have multiple analyses under my replicating Abramov study. So under my study, I can have lots of different cohorts, and I can have lots of different analyses of those cohorts. This first one was, this current one, I didn't give a name to. And this one is the one I had done before of the single cohort outcomes. I can duplicate these, I can delete them, I can manipulate them a little bit here. But again, I have an umbrella study that has multiple cohorts I can do things with, and I can have multiple analyses that use different cohorts that I created in those queries. And at any time I can go back to my cohorts, I can make a change here, limit this to patients of the different age or different dates for phenomena or what have you. And then my analytics, if I duplicated an existing outcome like that, and then swapped in a modified cohort, it would retain all the decisions I made about what kinds of propensity variables to include and what kind of outcomes to measure. All it needs me to do is to set up the time window and the index event and then run through the steps again, but it doesn't ask me to re-input those 10 selections of propensity score variables or specifying dyspnea and specifying death and things like that. So it does a nice job of making it easy for you to go back and forth between modifying queries and modifying analyses without having to start over from scratch with these. And I can give this a name. So it's not just unnamed. So I have my outcomes comparison and my single cohort outcomes. And if I go back over to my query builder, I can remind myself what's in there or make changes. Okay, that's the end of the demo. Any questions about those steps or anything about TriNetX that you have questions about?
I have a question. This is Robert Sabota. I'm one of the SCI fellows. Just because you use the example of spinal cord injury, can you drill down a little further on, or do you have the ability to drill down a little further on like cervical versus thoracic
Sure.
spinal cord injury?
Yes.
Like if you wanted just to take it one step further to tease out people that might have respiratory issues versus not?
Sure. So I could go in here and I could say, well, what is it going to give me the, yeah.
Maybe cervical. Yeah, okay, cervical. Yeah.
Mm-hmm. So I can go in here and I can click on the caret and bring up as fine-grained ICD-10 codes as you want to do.
Okay.
So anytime there's the right caret, you can click on that and see all of the subdivisions for these or the old ICD-9 terms and things like that, and build up from specific ones. Or also, sometimes people can have multiple kinds of cancer, multiple kinds of some injuries, I assume, also in your area. So you could also say, I want these kinds of spinal cord injuries. I don't want these other kinds of spinal cord injuries. Or if you were looking at dementia, you might say, well, I'm interested in Alzheimer's. I'm not interested in vascular dementia. So you can drill down a couple of different ways that way.
That's great. Thank you.
Yeah, good question. Other questions? All right. So do you all have any abstract submission deadlines coming up? Conferences coming up that you could submit TriNetX studies to? All right. Well, feel free to reach out anytime. Happy to work with you, as Amol said earlier. The first time you go through one of these, it helps to have someone help you to get over some of those learning humps along the way. So happy to do that with you. Just give a holler.
And thanks a lot, Brian, for your time and going through this. Really appreciate it.
You're welcome.
Thank you very much.
Sure thing. Take care.
Thank you.